Today we're going to talk about evidence-based practice, levels of evidence, and so on. So what is evidence-based practice? What used to happen in clinical practice is we did what was based on what our seniors had taught us, based on notes, what is traditional knowledge. So that is when you practice based on habit, you're going from an upstanding researcher or an upstanding clinician to a poorer clinician. Whereas the trend is reversed if you do your clinical practice based on research. From what you don't know, you learn more and more, and you become better and better clinician, which is the point of doing evidence-based practice. Now, how do you decide? How do you get the best evidence for optimal patient care? Then you need to have evidence-based practice. It needs to be safe, needs to be careful, needs to be systematic, based on the best available evidence. Evidence is based on research. Now, there are different levels of evidence, and there are different types of articles and different types of research designs. So, what are the sources of evidence? Sources of evidence are clinical expertise, scientific research. There are three pillars. For optimum patient outcomes, for the patient to get better optimally, you require the best research evidence with clinical expertise that is administered with keeping in mind patient's values and circumstances. So you may sometimes not be able to do the best evidence, the best clinical practice that is possible, either because you do not have the expertise, or because the patient systems does not allow you to do so, economic, values, or the patient's beliefs, and so on. So evidence is an amalgamation of the three: best scientific research with clinical expertise based in patient's values and circumstances. This will give you best patient outcomes. So to go to evidence-based, how do you get this evidence? It is easy. You hear this term all the time: evidence-based practice, evidence-based practice. Now, how do you get evidence? First of all, you need to identify the need for information and develop a focused and searchable question. You need to have a question, because you cannot say, I want to find the evidence to treat cancer. It is not like that, because there are many methods, there are many types of cancer, and there are many stages, and so on. So you need to identify the need for the information, and you need to develop a focused and searchable clinical question. Searchable clinical question means the question must be articulated in such a way that it is possible to search for the evidence. Once this is done, you conduct a search to find the best possible research evidence to answer your question. The best possible research evidence may be meta-analysis, it may just be traditional knowledge or case reports or expert opinion. You do not know. So, for the best possible research evidence is the best evidence that is out there, that is available in the literature. Some of this might be good quality research, high quality research, or some might be very low quality research. So you need to critically appraise. Next point is you need to critically appraise the research evidence for applicability. Now, this is basically the focus of this entire seminar, to identify how do you critically appraise and appraise evidence, literature, so that you can find whether it is worth following or not. Critically appraise research evidence for quality. When we talk about critical appraisal, we are talking about quality, research quality. And then if the quality, if it is sound and the research design is robust and the research is being done ethically and robustly, then you see whether it is applicable to the population at hand. Then you need to integrate the critically appraised research evidence with the clinical expertise available and patient's values and circumstances, and that That is when you start. That is how you start practicing evidence. Then you need to find out if your new method of treatment is actually working. That is, you need to evaluate the effectiveness and efficacy of your efforts and identify ways to improve them in the future. So you need to see whether what you have found the best evidence through steps 1 through 4. Then you do it on your patients for some time, and then you evaluate again. You synthesize this evidence again and see if what you have read in the literature and applied in your clinical practice is actually effective in your population. This way, you are adding to the evidence and you are making your practice more better. So what is evidence-based practice? Definition is it is the conscientious, explicit and judicious use of current best evidence in making decisions about the care of the individual patient. It means integrating individual clinical expertise with the best available external clinical evidence from systematic research. This has been given by Sackett in 1996. But every word here is important. It is conscientious. Evidence-based practice is conscientious. You must take a lot of trouble to understand the evidence. It should be ethically done, and it must be done with a lot of interest and application. It is explicit. You cannot have vague questions. You need to have focused, clear questions so that you can get explicit information. And it is judicious use. Just because treatment A appears to be good, but it is extremely, appears to be better than treatment B, marginally better than treatment B, but it is extremely, 4 times more expensive, then you would not go for treatment A, even though it appears to be better. It is a judicious use because it is also patient's values and preferences. For 5% better outcomes, you are not going to make the patient bankrupt. Use of judicious, use of current best evidence. Current best evidence. You must understand that evidence keeps on changing. As you get more and more literature, you get more and more systematic reviews, more and more meta-analysis. What was best yesterday may not be best anymore. You need to use this to make decisions about the care of each patient. That is evidence-based practice. So, if there is research that has been done on a large number of people and it appears to be doing well, then you do it on your individual patient so that you know exactly. So that is why you must pay attention to the type of the patient characteristics that have been done in the research so that you can apply this in your patient. Does it mean that does your patient match the criteria for this particular treatment? It also means integrating individual clinical expertise with the best available external clinical evidence from systematic research. The best available external clinical evidence is what you get from research, and you must have the expertise to carry out those treatments. Otherwise, you would not be able to do that particular treatment. That is evidence-based practice. Why do we do evidence? What is the need for EBP? EBP aims to improve the care of patients, carers, and communities. It reduces the variations in practice. So, if you have from EBP, from literature, you get current practice guidelines, you get consensus statements, and the expectation is that everyone in that country or in that society will follow the same thing. So, if I have gone to a patient in city A, to a doctor in city A, and XYZ has been done to me. With this information, I go to some other city. There should be seamless continuation of my treatment without any change. They should not change the medication, or they should not say this is not the right thing. If EBP is followed consistently, then there will be seamless management through consensus statements and standards of care. You need to use evidence from high quality research to inform practice, balancing known benefits and risks. One of the most important things that all healthcare providers must remember is that we should not do harm. So if there is evidence of adverse effects, then you would not do this particular treatment. So you need to know benefits and risks. That is another thing that you would appraise for. You need to challenge views. EBP helps you to challenge views based on beliefs rather than evidence. Beliefs are judgmental. Beliefs are based on what you know, what you have seen. It is not empirical evidence, and it is not, and it cannot be believed. Need to It aims to make decision making more transparent. I can say that if the patient has this characteristic, this is the treatment that has been found to be effective, and that is what I'm going to do. So there is transparency. This information can be passed on to the patient, it can be passed on to other caregivers, it can be passed on to policy makers, and it can be passed on to third party payers. So you know that you are doing the right thing, and everybody knows that you're doing the right thing. It aims to integrate patient preferences into decision making. Now, the patient might say, you tell the patient that from the best evidence that is available now, this appears to be marginally better, this appears to be a marginally better treatment than the other treatment. The patient says it's okay. I don't want to go through the trouble of having surgery and go for conservative management, even though I understand that my outcomes may be slightly worse. So that is up to the patient. It is not for the doctor to decide or the healthcare provider to decide. So you can integrate patient preferences into decision making. So when we do systematic reviews, we can also include patient preferences that would be in mixed methods reviews. Ensure that knowledge continues to inform practice through lifelong learning activities. If you become an evidence-based practitioner, then it gives you it's the onus on you to remain on top of the current evidence. So that will inculcate lifelong learning activities. So you will tend to read regularly, as all of us should be doing. There are some misconceptions about evidence-based practice. This says that just research could have been done by academicians who are out of touch with clinical practice, and they don't know what's going on in the hospital. They don't know what's going on in clinical experience. They are sitting in labs and doing something, and it does not value clinical experience. How can they say that something that they have done on mice is better than what I have been doing for 20 years of my clinical practice? I have seen over 1,000 patients. I have done this and they have all done well. So that is a misconception, because evidence-based practice takes clinical expertise with best current evidence, best current scientific evidence in view of patient preferences. Another misconception is that it only admits RCTs as sources of evidence. There are levels of evidence. So there is a hierarchy where randomized controlled trials, by virtue of the fact that it is the least biased, occupies the highest place. But it is also, but it does not mean that that is the only trial or only evidence that is admitted. Even cohort studies are admitted. Depends on the best available evidence. And there is another misconception that it provides a formulaic approach to practice or protocol, saying that this is what has to be done and so you have to follow that protocol. That is again a misconception. It is based on clinical experience, clinical expertise, and the patient's values and available resources. So there is no formula. Some of the barriers to EBP that all of us talk about. We all say, oh, I would love to do evidence-based practice, but I just don't have the time. Excuse me. I don't have the time. That is not true. Because if you can make it into a habit to read current evidence, now it's so easy. You can have your articles on your telephone. It is now, if you read an article a day, or if you read one systematic review, or if you read up on current consensus statements and current practice guidelines regularly, you set apart a day, or you set apart 4 hours a week in order to do this. It is quite possible. Another people say that this research was done in US. It was done in high resource settings. It is not generalizable. It is not possible in our country. That is also not true. Most of the things that are possible elsewhere is also possible in our country. And like I've been saying, it is the best available research in considering the resources you have. So the highest level of evidence is not possible to be practiced in India. Then you might have the next level, which is good enough. Then people say that you have lack of I don't know how to do research. I'm a clinician. I'm not a researcher. Well, that is why you have other people doing research, which they publish, and all you need to do is read it. Lack of understanding of statistics. Now, this may be something that has to be overcome. But if we are conscientious practitioners, healthcare practitioners, we need to be able to understand some amount of statistics so that we can at least interpret what is there in the studies. That is something that we should take upon us as lifelong learning skills. Lack of search and appraisal skills, it's very easy. If you can get into the habit of it, searching and appraisal is not difficult. We have any number of software now. Lack of information resources may be a barrier to many practitioners in India because we may not have access to all the databases. But Cochrane database is available for many of the studies, but some others may not be possible. But then again, there are large number of clinical guidelines and practice guidelines which are freely available for anyone in the world. So these do not require any sort of membership. There is an inconsistent culture of EVP in India. We are still, only a few elite institutions are probably insisting on evidence-based practice. The rest of us are still going with traditional practice. Many of our textbooks are dated. We may not be up to date with the latest technology, may not be up to date with the latest information, and we do not have a system of reading articles. Now, even though most universities have a system on paper of doing a journal club and so on, these are rarely done with a great deal of interest. Now, what is a searchable clinical question? A searchable clinical question must be focused. You must be able to search it. So focus. You should know what kind of patients are you targeting. Are you looking at older people, younger people? What kind of men, women? Are there any other variables, any demographic, anthropometric variables, or any other variables that might be important to us? So you need to have focus on the clinical question. The question must be searchable. So the question, you should be able to say, I want to know about adults who have cerebral palsy and who have undergone orthopedic surgery. So you want to know what kind of management you're thinking about. And what is the outcome of interest? I want to know if adults with cerebral palsy, if they undergo orthopedic surgery, are they going to be able to walk better? So, the patient characteristic is adults with cerebral palsy. Patient management is orthopedic surgery. I'm just saying orthopedic surgery now. Of course, we need to go into more detail. Is it soft tissue surgery or is it bony stabilization? We need to go further. But right now, we will say orthopedic surgery or we'll say Botox injection. Outcome of interest is gait. Are they able to walk better? So, every question must have the patient characteristic, what management, what exact treatment are you trying to search for, and what is the outcome you are looking at. When you come to RCTs or actual research studies, you have the type of statement. P is for patient problem. Now, how would you describe a group of patients similar to yours? So, what kind of patients are you looking at? What are the most important characteristics of the patient? In the earlier example, they had cerebral palsy and they were older adults. And they were adults, they were not children. So this could be the primary problem, disease, coexisting condition, sometimes gender, age or race may be relevant to the diagnosis or treatment of a disease. So in a child with CP, you have a different approach, and in an adult with CP, you have a different approach. So here you need to know the age of the patient and you need to know the primary diagnosis. The I in PICO stands for intervention. Intervention, or in other kind of studies, it could be prognostic factor. If you are looking at long-term longitudinal cohort studies, you might be looking at prognostic fracture. You might be looking at exposure. If you're looking at does inappropriate orthotic devices cause bony changes in the foot in people with cerebral palsy. So you're looking at exposure. How many years of bad air force have you used before this happens? So in this case, what are the main interventions of prognostic? Which is the main intervention, prognostic fracture exposure, that you're considering? You have one purpose. You're looking at gait, or you're looking at bony abnormality. What are you looking at? What do you want to do for the patient? Do you want to do orthopedic surgery, or do you want to look at what has been how long they have been wearing orthotics? So one would be for exposure, the other would be for intervention. C would be comparison. So you need a comparison group. Now, how do you know that it is not because of this patient's particular characteristics that XYZ happened? So you need comparison. So in comparison, you need an alternative. So is orthopedic surgery better than Botox? So like Botox is a comparison. Or do people who wear AF4 have bony abnormalities compared to those who wear some other type of orthotic device, a shoe insert? So that would be the comparison. And then you have outcome. What have you tried to improve or affect? Have you tried to improve the gait? So your outcome is gait, or in the second example, your outcome is bony abnormality.